Hello and welcome back to the Weatherford College EMS podcast, where education meets experience and textbooks meet the street. I'm your host, Tyler Holland. I almost said my last name wrong. Can you believe that?
Dang.
It's my own last name. I'm also known as the NIH man, which is easier to remember. I've got Adam Parish over there. He's our EMS historian. We got Samantha Grimsley. She is our been there, done that career guru. Anyways, we're kicking off with a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. We're going to be talking about some anaphylaxis-related medications, right? Some immunology?
Yeah,
how do you say it?
Immunology.
There you go.
So realistically, y'all, when we sat down to do this podcast, we thought about it and we're like, well, we've already really talked about these medications a lot in the respiratory section. So I think the ultimate thing today is that we're going to kind of just utilize them in the sense of how do we go from an allergic reaction treatment protocol versus an anaphylactic treatment protocol, and how the narration of those two things kind of flip in that instance. And so we're not going to hit the medications too hard because you guys can review all things that in the earlier podcast. But starting right off the bat, an allergic reaction can just be anything from a small trigger of some kind of allergen, whereas an anaphylactic reaction is a severe reaction that involves two or more systems, which is anything from a skin or mucosal involvement, GI involvement, a respiratory involvement, or even in the sense of like hypotension, some kind of cardiovascular involvement in that sense. So you have to have two or more of those organ systems involved to consider it to be an anaphylactic reaction. And so the treatment protocol is very different whether you just got, I've got urticaria going on from a mild reaction and having an allergic reaction versus I've got full-on hypotension, wheezing, some angioedema, and everything is happening. Where do we go with that? So kick it right off, let's go allergic reaction first. The simpler, the easier of the things. First thing you do, even if you're at home, grab the dose of Benadryl, right?
Yeah.
So one thing that I always like to talk about is Benadryl does not just take all that histamine release that's already been released and just make it go away. All it's doing is stopping new histamine from releasing. Mm-hmm. It's saying, hey, we recognize there's a release, but we're going to put the floodgates up and stop it from having any more come out. We're always going to have the stuff that's circulating still, but we're just going to stop any new release. And that's the biggest thing that I like to take home on that one.
It's kind of like the aspirin of the allergic reactions, right? The aspirin's not going to fix the heart attack, but it'll help prevent it from getting worse. So think about that with your Benadryl as well.
Yeah. Wow, I brain farted for a second. There is another histamine blocker out there, but it only works on H1, not H1 and H2. Do you guys remember which one that is?
Phenergan.
Yeah, there we go. So some people have said that they've tried using that in allergic reactions before. I'm not really sure how that one...
Well, I've seen anecdotal evidence that it could be beneficial. Think about, especially if you're having the GI-related allergic reactions, right?
Okay.
Yeah, but let's take this, to another step, right? Is Phenergan just as effective as Benadryl?
In what regard, though?
In treating even a multifaceted allergic reaction?
I would say no.
Okay, so that's why Benadryl is your go-to, right? So we can have
Absolutely.
other drugs that have that H1 effect. Okay, and
Yeah.
that's my point. Is we can have these other drugs that have a little bit of this and a little bit of that and can help with this, and if they can't take this, then we'll reach for that. But there's a reason why we always kind of go with the first.
Yep.
Right? There's a reason why we say, well, we got to start here. And generally with those kind of allergic reactions, really any kind of allergic reaction, our first go-to is Benadryl.
Yep.
And so even though Phenergan, it might sedate them, might make them feel a little bit better, whatever, it's not as good at mediating that that histamine release. And because of that, like Sam was talking about, it's not as effective at stopping the reaction. And it's not even, it's ceasing all of that release.
Yeah.
It's ceasing the result of the reaction. That's really what is kind of getting to you, right? So generally when we refer to these reactions, we're talking about the IgE cell-mediated reactions to some kind of anaphylactoid or something, some such that's causing this, right?
Yeah.
And Benadryl's it's the proven way to go.
It is,
Yeah,
and
definitely.
one of those things, we see in the field setting, and even at home, the dose is the same whether you're giving it IV or giving it PO. It is exactly, or even IM. There's so many different ways we can go with this, and this medication can be given. But one of the things that I like to preference is not everybody reacts the same when giving Benadryl. We see some people that get into that drowsy, I'm gonna go sleep off for a while.
That's me.
And then you get some people who take Benadryl and they are super hyperactive.
Yeah.
I will clean your house. Give me some Benadryl. But, even so much that when I took my son to see his allergist, they said, if you're going to give Benadryl, please don't do it before you get him on a plane. Because they just didn't know, if he's going to have the same reaction that I do.
It's true.
Yeah,
you don't want to be 30,000 feet in the air going 500 miles an
exactly.
hour in a metal tube with a kid that won't settle down.
But the other thing of it is when I take Benadryl, I actually feel very full of secretions, and I get
Really?
this feeling like I'm drowning in secretions, and which is interesting because when we talk about the next medication that comes in the allergic reaction protocol, albuterol and Atrovent helps to dry up those secretions. And so I've never actually sat there and said, well, I gotta take an A&A treatment next when I wait,
Well, and that's interesting, right? Because Benadryl is actually supposed to dry you up. Benadryl has
but
the
it all,
anticholinergic
but look at it,
effects.
I'm doing the opposite
I
as
know
it is. So
That's
it's
what I'm saying,
interesting.
It's interesting, right?
Case in point, not every patient is going to react the exact way you might think they will when you give them that medication.
Absolutely.
And just to keep building on that point about your particular reactions to Benadryl is, it's an anticholinergic, which is also known as a parasympatholytic, meaning cutting off the parasympathetic nervous system. So it might let the sympathetic nervous system play a little bit too much. So that might be why that you have those symptoms of feeling like you're bouncing off the wall.
My central nervous system's just rewired funny.
It just does whatever it wants. Yeah.
So, as far as that goes, there's not a whole lot more that I would add to the Benadryl aspect. It's a pretty commonly used medication. I think a lot of people use it in their sleep aid medications. If you haven't ever looked at, if you go to get NyQuil, or not NyQuil, but the nighttime medication, you sometimes have to look, and so I know I do when I'm going in there and I'm drinking the nighttime flu and cold, to go look at the properties of what's in the nighttime aspect, because that ain't gonna be nighttime for me.
Yeah.
Just two more things to add to that is number one, obviously patient history. We've been beating it into your brains now. Hopefully it's starting to stick. But if your patient's already been taking lots of Benadryl and we give them enough, you might push them over the edge of kind of an anticholinergic overdose.
Yep.
Which where you're going to start getting to the red as a beet, mad as a hatter, etc. And you want to be very cautious with that. And some patients actually use it recreationally. So if you didn't know that, now you do.
Yeah, I know people who just take it because they wanted to go to sleep, not because they need it, but just they want to use it for
to
sleep.
sleep or even to get high.
Yep.
And you might have those patients say, after you give them a medication that they needed, whether it be pain, nausea, etc., they say, "Oh, I'm allergic to that." Well, you didn't say that before I drew this up. You didn't even say it when I asked you if you had any allergies, because they want to get that Benadryl. Some of them really like the way it feels. So just be mindful and cautious with those scenarios.
Yep, absolutely. So kind of moving on into the albuterol and Atrovent aspect of it, we already know that albuterol is a smooth muscle relaxant. It is going to help with bronchodilation. We know Atrovent is going to help dry up those secretions, stop the bronchospasms and everything of that sort. So, we've stopped the release of the histamine. Now we're going to take that respiratory system, we're going to open everything up, we're going to start to dry everything up and start to make everything a lot better. And then, we throw on a steroid, whether it be Solumedrol or Decadron, and we're going to help with the inflammation, knowing that it's not going to be immediate. It's going to take some time for it to happen. And then, in some protocols, some protocols will even say at that point turn to epi. We'll talk about that more on the anaphylactic side. But, realistically, that's where the protocol ends for an allergic reaction, unless you guys have anything else. I mean, we do know that tributylene and magnesium sulfate are out there. Both are smooth muscle relaxant bronchodilators, kind of the same thing. We talked about in respiratory of seeing tributylene come out when A&A treatments weren't really allowed because of wanting to expel the nebulizer. And we know that mag can be used for severe bronchospasms.
Yeah.
Again, putting them on end-tidal would be exponentially the right thing to do here, looking for that shark fin kind of waveform, and then reassessing those lung sounds and checking over our patient. Now, on the other end of the spectrum, anaphylaxis.
Yeah, with these anaphylactic type reactions, we need to change the order in which we're giving our meds.
Yeah.
Right. This is something where when you arrive on scene and you take your first look at your patient, if you think that this is becoming that anaphylactic reaction, okay, this is one of the very few times that we're just going to start reaching in and treating.
Yep.
Because we can lose our patient very quickly.
Yeah.
Depending on the speed of this reaction, how severe of a reaction they're currently having. And honestly, when we get into those anaphylactic type reactions, you can have a delay where you show up and you're like, oh, this isn't too bad, and why are you not breathing? Right?
Yeah.
Even though it took you 10, 15 minutes to get there after the exposure. Or it could be something where you're rolling up and you're like, I don't hear breath sounds because their throat's closed. Oh my God, what am I going to do? This is one of the very few times, and what we're going to reach for is our epi.
Yeah, you got to be proactive, not reactive in these patients.
Absolutely. You have to be aggressive.
And you have to be multitasking at the same time, because you have to be asking questions if you have somebody around to make sure that you're putting what you're seeing and your assessment and what is going on. And I know for me, like, I've ran a really nasty anaphylactic reaction, and the patient's family just happened to say, well, she just got home from the pharmacy. That was about all I needed to trigger in my head. That was like, here we go. This is exactly what's going on. And I mean, as quickly as that happened, we were dosing and everything. And by the time we got to the ambulance, everything was starting to back off and she was starting to feel better. And then it became, I just had a dental procedure and I'm now getting on these antibiotics and I've never had these antibiotics before. And it was like, bing, bing, bing.
Yeah. This is one of the few conditions where if a patient has a history of anaphylaxis, they're going to have a life-saving medication in their pocket. And the reason is time matters big time on these patients.
Absolutely.
They need that epi quick.
Yeah, and so, epinephrine, vasoconstrictor, helps with beta 2, has, all things. It's got the alpha and the beta principles to it. So
just everything. Yeah.
We know with anaphylaxis, we're
hard.
going to have some hypotension associated. And so in that sense, we're helping with the ino, the droma, the chrono, and helping vasoconstrict everything, and then also relaxing everything in the lungs and kind of working in full circle. So it's a great miracle drug in that sense. And
Absolutely.
We've talked about some of these drugs being full circle. So after epi, what do you go to?
Benadryl.
All right, so now we're going down that protocol.
Yeah, hit them with the Benadryl after the epi, right? You want to
Absolutely.
help get on top of that now.
And then we go into the whole albuterol, Atrovent. And I've even seen some people transition from epi into the steroid and then into the histamine blocker because they got to get the steroid on board and start helping. I mean, essentially, we're talking about mere minutes, right? We're talking about from one to the next, to the next, to the next. What we're saying is, don't just delay and take the entire trip to the hospital to give these medications. Be analytical, and if you're giving this, you're doing this, you're doing that. And so the protocol that you go to might be a little out of whack, but nonetheless, they're all going to tie back in the same. And I've even seen some protocols that say, hey, you can hold off on the albuterol and Atrovent. Once you've given the epi and you've given a steroid and you've given a Benadryl, kind of reassess, and maybe you won't need.
Yeah,
Absolutely.
and she brings up a good point too with the way that you're going to administer these. A lot of times you're going to be told, hey, we're going to start low and work our way up. This is not the case. This is where we're going to bring out the big guns first, and then we're going to work our way down, right? The main thing is get the epi on board. Honestly, that's when I start reaching for the Benadryl, because it's pretty simple, right? We're going to give 25 or we're going to give 50 milligrams of Benadryl to our adult patients, and we're going to give that real quick, and then we're going to move on to the next thing. And if that's a steroid, if that's an A&A, however you're going to manage it, that's when, your discretion comes up, and when deciding what that patient needs, when they need it, and how they need it.
Yeah, you just made a very good point that I want to make sure we reiterate is when we're talking about epi, there are multiple ways that epi can be given.
Mm-hmm.
And then it also comes back to the concentration. So knowing if you're going the IV route versus if you're going to go sub-Q, knowing when to use 1:1 versus 1 to 10,000 in that aspect, and then thinking about that. You need to make sure you are writing your drugs, you're checking it over, you're having that thought process and doing right by that patient, and remembering that, sub-Q might be your only option. And again, it's not going to be IV. It's not going to be immediate. It's going to take some time to metabolize into that fat. But, it's just something to think about in that aspect when you're giving your dosages and your medications and everything of that sort.
And I want to bring up one other concept, right? Remember, we've talked about it a few times, too, of loading dose and maintenance dose.
Mm-hmm.
Okay? You can give your 0.3 to 0.5 milligrams, or I'm sorry, 0.3 to 0.5 milligrams IM epi to start off with. Start working your way down the protocol. If you find that then the reaction starts coming back, or perhaps they have a history, right? My dad's allergic to bees. He knows this. He's had those reactions before. And because of that, if I was treating my father, I would put him on an epi trip.
Yeah.
Right? Because I would want to maintain that vasoconstriction,
Mm-hmm.
because he's had this reaction before.
Ooh.
He cannot and will not just bounce back like the first time somebody is having this reaction. They're going to continue until whatever has caused that reaction is gone, is metabolized, has been, gone through whatever process that it needs to go through to metabolize and shift that out of the body.
Let me ask you a very, very fair question on that. Let's say your dad has given himself his EpiPen before you arrive, and he's still showing symptoms of an anaphylactic reaction. Do you then move straight into the Benadryl, or do you give a dose of Epi?
I want to look at the pen.
Ah.
Yeah.
It's a great...
I want to look at the pen. I want to look at the date. I want to
Yeah.
make sure that it looks legit. I want to know, and I want to ask him too. We know what effect epinephrine is going to have, right? We know that it's especially, it's going to have the inotropic, the chronotropic, the dromotropic. It's going to affect all of those things. So if I don't see a reaction, if I show up and his heart rate's 80,
no.
I don't think that
Nope.
I'm not going to think that epinephrine
We know you
is
should
working.
be like, rah!
Yeah, no, it's not good. It's like when we give our nitro and we say, "Do you have a headache?"
Mm-hmm.
If they say no, guess what? Here's some more nitro. I don't care that you've taken 5 before I've gotten
Yeah.
it, right? I'm still, as long as your blood pressure is good.
We don't know
and
that
everything
Epi
else-
hasn't made it through the wash cycle a couple of times.
Yeah.
Yeah, exactly. I know. Yeah, I mean, you're not kidding there. So, especially if that's something they keep with them all the time, right? Like you never know. So I want to look at what they gave themselves, how much, what the date is, what it looks like,
Yep.
all those kinds of things. And honestly, again, I'm going to go back to be aggressive with these people. You will lose them quickly. And because of that, you know what? If they're still having a reaction when I get there, I'm giving them another dose.
Game on.
Yeah.
Now, I might not reach for my 0.5. I might say, okay, well, I'm going to go on the low end of that.
Yep.
I'm going to give my 0.3. But I'm not going to be scared to give them another dose.
Yep, absolutely.
Yeah. So to try and reinforce, set this all in stone, and kind of just reiterate those points whenever you're deciding after you've given your first round of Epi IM, do I want to start an IV or keep this going IM? Either way you go down that route will be acceptable, right? But with the IV infusion, you're going to set that on a drip and titrate to effect, of course. But be mindful that your IM injections, they're going to have they're going to have a longer time until you start to notice their onset. But also a little bit more beneficial is that it's the duration of action is actually going to be prolonged as well. So that Epi that you gave IM might be sitting around and doing its thing a little bit longer than if you were giving little push dose Epis through an IV.
That's good to know.
Yeah.
Well, also you need to make sure that if you're going to go IV, you're not pushing the 1-to-1.
Yeah.
Big time, yeah.
Be smart and
Yeah.
make sure you're writing your drugs,
Absolutely.
please. Do y'all have anything else that you want to add to this before we kick off this one?
Not really. Just know that at that point, once you have your epi on board, you've given your Benadryl. Always go back and reassess
Yep.
before we start, because we can give more medications, but we can't take them away.
Absolutely.
And it's something that we need to always have in the back of our minds, that we're here to treat the patient, we're here for a positive outcome, and we need to continuously reassess, especially when they could go so far one way or the other with this kind of situation.
Absolutely.
And, I just thought of something too. What if we get that patient that has angioedema, but not necessarily any other signs and symptoms of a systemic reaction, and you find out they're taking an ACE inhibitor?
Like lisinopril. That's a big
What do we do? It looks like a allergic reaction, right?
You treat the patient, not you got to go treat the patient.
You got to go with what's going to kill them first,
Yep.
right? And that angioedema, it can get to the point where you're going to have to cric them if it's specific to the ACE inhibitor relation, but you don't know. They could also be allergic to it. So you want to be cautious. You want to treat it with Benadryl at least and go from there.
Absolutely.
Just in case.
Well, is that about it, guys?
Yeah.
All right. Well, that's a wrap on this episode of the Weatherford College EMS podcast. Big thanks for tuning in as we kicked off this topic of immunology with pharmacology.
Yeah.
A topic that can feel intimidating, but we promise it gets clearer with every call and every repetition. From Tyler, the NIH man, to Adam, the historian, to myself, the field-tested perspective. We're here to guide you through it every step of the way. Stay curious, ask questions, and never stop connecting the dots between the medications, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not about just knowing the drugs. It's about knowing what they do and why. Have a great day, everyone.